me. I'm the moderator. Sorry.
Oh, sorry.
It's okay. Okay. Well, it's my honor to chair the session with Professor Shang Lin. Okay. Next, our next speaker is the famous Professor Kazuma Miyatake from the Department of Orthopedic Surgery, right? Yokohama City University Hospital. And he is going to talk in detail with us about the hydro release of the upper limb, especially the ulnar nerve, the radial nerve, the median nerve, the axillary nerve, suprascapular nerve, and all the cutaneous nerves, and also the brachial plexus and so on. And you also mentioned about the scratch test for your diagnosis, right? Anyway, thank you and welcome.
Thank you for the invitation. Hello, my name is Kazuma Miyatake from Yokohama City University Hospital. And I'm orthopedic surgeon and I'm very young. Please go easy on me. Today I'm visiting in Taiwan for the first time. I'm very happy to come here. So let's start. I would like to talk about scratch grafts test hydro release for pain and numbness of upper extremities. An orthopedic surgeon like me likes surgery. So surgery, and thinking about surgery all day. On the other hand, few patients need to have surgery to remove the pain. Conservative treatment may be the most practical option for the treatment of disorder in the upper limbs. The option of the conservative treatment for rehabilitation, compress and painkiller, and PRP and steroid. So there are many patients whose symptoms cannot be cured by physical therapy, but the condition is not an indication for surgery. And many patients still have symptoms even after the operation. There are many patients with refractory pain. So 2 years ago, I opened the Interactive Pain Center in Yokohama City University Hospital by myself and for these patients. So let me introduce the case we see here and our clinical practice. 50% of our patients have manipulation under C5-6 block on shoulder stiffness. And 21% of them come to confirm diagnosis or need surgery. And 64% visit us for the purpose of hydro release or hydro dissection. So today I would like to introduce how to diagnose the symptom of patients with interactive pain and how to treat them with hydro release. So I would like to talk about how to diagnose in detail. Among our patients, we see that some have no pain at all despite having poor imaging. And on the other hand, we also see patients experience severe pain without abnormal image findings. So, such as calf tears, also OA of knee, spondylosis, or hip joint lesions are unrelated to the pain. Moreover, it is common to encounter cases where the patient feels no pain, even if the cuff is broken. So, sometimes orthopedic surgeon says surgery has been successfully performed, but imaging finding was good after surgery. However, in many cases, pain or obstruction of movement remain. Here is an example. This patient had wrist bunker surgery at another hospital, but is still in pain with limitation in joint movement. No specific abnormal findings was determined. The patient is a judo athlete. Like this. So, what is happening in these cases? Is the joint capsule really stiff? About the shoulder movement, in normal cases, the head of the humerus moves slightly downward during the abduction movement. This allows the humerus head to slide under the acromion like this and making it possible to raise the arm. And the cases find it difficult to move the human head downward when the posterior part of the shoulder joint becomes stiff like this. So as a result, the human's head cannot maintain the centripetal position with respect to the joint and moves forward and upward like this. And impingement or cuff tear or inflammation. How to treat? Now I will focus on the axillary nerve. The nerve runs between the triceps, teres major, teres minor, and under the deltoid muscle. So, as for the cause of pain, we focus on the effect from the superlateral cutaneous nerve of the upper arm. Dr. Rose's method is known as a convenient procedure, but in these cases, the target is quite distal. So only the superlateral cutaneous nerve of arm can be injected with this method. Because of this, it is necessary to set the injection target at the more proximal side, called QLS, like this area. So, unlike with nerve block injection, in many cases of hydro release, it is difficult to obtain a good result without finding the specific target point. It is necessary to ensure the tissues are separated with solution so that they wrap around the target nerve. So apply the probe from the armpit with the shoulder joint adducted as much as possible. Apply the probe so that it touches the triceps with a short axis, like this. This is a method of Dr. Kevin Chan. This shows the axillary nerve running under the teres major and the triceps. Here. And to double check, confirm the triceps gets smaller as it becomes proximal and attached to the scapula. Method of Dr. Rose, this is deltoid, triceps, and teres major, and remove the deltoid. Green solution is Dr. Rose's method. More distal. Spread more distal. And Dr. Kevin Chan's method is more proximal. Just this area is QLS area. So let's see the judo athlete I introduced previously. She is a member of the Japan national team. This was taken 6 months after Bristol Banquet, and flexion 124 degree, abduction 118 degrees, and third internal rotation and 14 degrees. I injected this area, actually now, hydro release. Only use saline. Immediately after treatment, the range of motion has improved, like 124 to 140. And abductions dramatically change. 118 to 172. (57 to 64) and third internal rotation is dramatical change. 14 to 36. The same cases is here. The case with the 6 months of conventional treatment following the fracture of greater tubercle of humerus. The limitation of joint range is worsened than in the previous examples. Belt time movement level S1 level. The same technique as previous was performed on this patient. Flexion 123 to 138. First external rotation 62 to 76 and abduction dramatical change. (86 to 146). This condition was sustained after 2 weeks without rehabilitation intervention. The time is good. So, in my impression, the method is relatively effective for patients who have better range in flexion than abduction. But, however, the comparison between the range in the abduction and flexion itself is not enough to diagnose action nerve disorder. Are there any other simpler methods that are also reliable? So, we are focusing on scratch collapse test. This is case of abduction restriction. You can see the external mass. Okay. 90 degrees. So, you can see the external muscle strength fall when stretching the axial nerve area like this. The same hydro release is done. A clear improvement in range of motion can be seen. Is it a Davies test? Systematic reviews report that the test sensitivity and negative predictive rates are biased, like this, 15 to 92%. But although not perfect, this test produces some correct result. It is definitely a useful test. So, it is currently used as support for several tests. Especially, it is used in combination with indirect nerve compression test, direct nerve compression test, nerve tension test, manual muscle test, and scratch collapse test. So let's look at approach for each one. Let's see direct nerve compression test first. Direct nerve compression test is limited to tenderness of the nerve. When we can see the actual images, direct nerve compression test is useful. For example, it is useful as a cubital tunnel which is clearly identified. Generally, the diagnostic accuracy of tender point is as lower as 64 to 81%, even for large joints such as the knee. So, examination of nerve compression test is done under ultrasound guidance. Under ultrasound guidance, it is possible to do direct nerve compression test of the radial nerve and, for example, on the branch of the superficial fibrillar nerve. ここから嫌なんだよね。ここから嫌でしょ。ここまでは平気なんだよ。Like this. ここから嫌なんだよね。Very small nerve. So the accuracy of ultrasound guided palpation is over 90%. But palpation only is unreliable. For example, neuropathy at the cervical level causes tenderness to be provoked in the distal area, so it is necessary to find the specific point for the treatment. So, indirect nerve compression test can also be used here. Indirect nerve compression test is similar to special tests. Example are the Sparring test, Jackson test, Parent test, and the loose test is also an indirect nerve compression test. This will be explained later. Next, physicians always use nerve tension test when they diagnose neuropathy. Nerve tension tests for the upper limb have become popular in recent years. In testing, tension can be created in the ulnar nerve by flexing the elbow. So there is no tension in the ulnar nerve when the elbow is extended. On the other hand, when applying the valgus stress at the flexion position of the elbow, the whole ulnar nerve gets tense. Tension is created in the radial nerve by the pronation of the forearm and internal rotation of shoulder. So the radial nerve becomes similar condition too. The shoulder internal rotation, the elbow extension, and forearm internal rotation apply tension to the radial nerve like this. But there is no tension in the radial nerve when the elbow is flexed. And in addition, several original tension tests has also been performed. For example, to test the suprascapular nerve, the scapula is pulled down in the adducted position to produce the greatest tension, like this. In dissection, tension is not normally visible, like this. No tension. But we can see the tension grow when the shoulder joint is pulled down and in the adducted position like this. This is tension. In actual cases too, pain is induced when nerve tension test is performed on the suprascapular nerve. She felt painful. And although it is a basic test, manual muscle test is also important. For radial nerve neuropathy, refer to MP extension of fingers. Before MMT, she didn't realize herself that her muscle strength was weak. After hydro release, MP tension of fingers recovery, like this. So, diagnosis is made by combination nerve compression test, nerve tension test, and manual muscle test and scratch corpus test. So now let's look at specific steps in diagnosis and treatment. So before that, if you search for popular sports in Taiwan, baseball comes out on top. So last topic is the medial elbow pain of the baseball player. Many baseball players with medial elbow pain come to visit our hospital. So generally, if baseball players have medial elbow pain, take MRI and diagnose ulnar collateral ligament injury, and do conservative therapy like rehabilitation or injection for 3 months. But if these treatments are not effective, we may choose UCL reconstruction. Every case responds the same way. So, when the elbow surgeon sees a painful medial elbow pain, they always say UCL reconstruction is the best. They have no longer considered the differentiation diagnosis. This diagnosis and the treatment started from 1986, since Tommy John surgery was announced, UCL regular reconstruction continued to increase until 2011. So, because of too much surgery, there are some rumors in Japan. When baseball players had flu, they usually be hospitalized and have usual reconstruction operation with or without medieval pain. It's joke, but many surgeries are being done in Japan. Is this choice good for baseball players? This is an MR image of a professional baseball player in Japan playing at the major league. Bone fragment with UCL have been confirmed. No UCL fibers. At this stage, the case would go to surgery both in Japan and United States. However, I did not choose surgery for the reason that there no pain. Yet here is an MRI image from 4 years ago. The baseball players has felt no pain in the subsequent 4 years and is currently very active in MLB, Major League level. So in America, in recent years, papers have finally been published stating that UCL surgery has been overdone, and I agree with that opinion. Surgery for UCL injuries is really necessary in only a few cases. So Japan and the United States carry out too much surgery over treatment. So let's take a look at the cases. A 16 years old pitcher who tested position of moving valgus stress test. Another doctor diagnosed UCL injury. Nerve tension test, ulnar nerve, positive. Opponent's disease, minimum muscle, MMT, weak, very weak. And loose test, this is nerve compression test, modified loose test. Ulnar nerve area, sensory is down. And actually nerve is not down. This is scratch crack test. There is a level. There is a level. C5 to C8 level forward. So the angle of the elbow is almost the same, similar. Nerve tension test and moving valgus test is similar test. So the angle, this time I guess UCL injury or disorder of ulnar nerve. So, but MMT indicate ulnar neuropathy. But however, if you combine loose test and scratch collapse test, you can see that it is thoracic outlet syndrome. So, in these cases, a C8 hydrolysis is performed like this: 8, 6, 8, 7, 6, 5. This is 8. C8 hydrolysis. Like this. So after injection, nerve compression test, no pain. MT is recover. This test is negative. Stretch collapse test is negative. So let's take a look at next cases. Moving valgus stress test is positive. Tinel test, Tinel sign is positive. Direct nerve compression test, painful, but C5 to C8 have no pain. Ulnar nerve tension test is painful. Median nerve is negative. Radial nerve also negative. Stretch practice test. So, the ultrasound confirms UCL damage, but at this point we consider ulnar region around the elbow joint. So, if you look closely, you can see that the trachea has a bone spur and the ulnar nerve wraps there, as with a dislocation like this. This is ulnar nerve and dislocation like this. Trachea spur, bone spur. So, cause of pain was not UCL injury, so ulnar nerve, and I inject hyaluronic acid to ulnar nerve like this. All tests become negative after hydro release. So, as you can see, in some cases, it is difficult to determine whether the symptom indicated TOS or ulnar neuropathy. TOS can easily be ruled out by conducting various tests in this way. You can see that ulnar neuropathy is indicated. So, thus, it is important to make a much faster diagnosis. After correct diagnosis, hydro release is effective. But the mechanism is not unknown. We don't use D5W, we use saline or hyaluronic acid. Last topic, lidocaine injection under the cyst is more rapid and effective than outside of the cyst. So, cyst structure, paraneurin is a key point that we think why is the hydro release effective. The reason why the cyst structure is important for understanding the mechanism of hydro release, it is related to nerve neuron. Nerve neuron was reported on the Lancet in 1883. Neurons are nerves around the nerve and it is related to the pain of nerve disorder. In addition, from the point of view of hydro release, nerve disorder does not cause only strangulation, but also sliding and more injury mechanism. So, static anatomy is insufficient, so I think the important thing is dynamic neuroanatomy in future. This is sciatic nerve of cadaver